for people. The first sort of basic principle is this idea that kids are not little adults. Although sometimes they're things that are important, biologically, there's a lot of differences in how children metabolize medications or handle medications. And sometimes the rules that we practice in adult psychiatry don't always apply to kids because they don't handle the medicines the same way or things look different. And I think probably the thing that is most important that I do is always remember development. And I know we have a lot of people with the CED here. Development's hard if you haven't had a wide range of exposure to different developmental stages, especially for parents. And so often as parents present with their kids, they're often the reporters of behaviors or concerns. And sometimes those concerns actually are appropriate. I give the example of a lot of our kids having a really hard time with the pandemic. And unfortunately, some of those outcomes, like increased hyperactivity, problems sitting still during a screen, challenges sleeping, not all of those are fixable with medicines and are really developmental outcomes of sort of shift changes or sleep changes or things. And again, it's not the same sometimes for kids to present with things. And so always have to kind of put on my developmental glasses, so to speak, and see, does this make sense for the context, and are the interventions necessarily being met? Because often medicines aren't the answer, and that gets to number 3. But just remembering that how kids handle how things are not always as predictable sometimes as what adults observe. Number 2 is really making sure that kids have had a complete evaluation. Sometimes kids come to me with diagnoses. Sometimes they're correct, sometimes they're not. Really just want to make sure that the child had a complete evaluation and that I'm down the right path. And I use the example of ADHD again as an option. For me, everything in child and adolescent psychiatry looks like ADHD. Probably 80% of what I get questions about are concentration, focus, attention problems, school issues, behavior problems, and people are worried about ADHD. Now, lots of those kids do have ADHD, but sometimes that's not correct. Sometimes what it looks like on the outside doesn't match what's driving it. So I sort of consider ADHD in children as a fever of unknown origin. It's a symptom cluster sometimes. We have to really figure out the cause, because it turns out kids that are anxious, kids that are depressed, kids that aren't sleeping well, kids that have been traumatized may all look the same, even though they may have very different causes, and you really have to kind of tease that out. So in order to really figure out what medicine is best, we have to really make sure we understand all aspects of the problem. Number 3, have non-medicine options been considered? Is medicine the best choice, and can it really help? 3 and 4 really go hand in hand. Sometimes medicine is the right answer. Sometimes it's not going to help at all, and it might make things worse. So really, I tell people it's not a yes or no, but it's a did I consider kind of the risk, benefits, and side effects of all these choices and making the best choice for this child and this family based on that. Number 5 is sort of an understanding that there are different ways to approach medication management. Sometimes we are really good and we know exactly what somebody's diagnosis is. It's accurate, and we know what medicines. We have lots of data that suggests how we should treat it and what to do if the first line of treatment fails, we move to the next. ADHD is a great example of that. It is probably the most studied diagnosis in all of childhood. There are hundreds and hundreds of studies about ADHD. We can really know what we're doing and understand it. But sometimes we just don't have as much data on things, or sometimes symptoms are really vague. You guys know what vague symptoms are. What are the vague symptoms that are really hard sometimes to figure out the cause? Anybody want to throw any out there?
And feel free to chat in as well, Elizabeth, and I can read it out for you guys.
Focus.
So I'm not sure what always vague symptoms you get, but I get symptoms from they're irritable, or they're cranky, they're having tantrums, or they're tired all the time, or they're not sleeping. And those are more symptom-driven sort of choices about things. where maybe you don't know fully the diagnosis or the cause, but you have this really impairing symptom that's present. Maybe it's self-injury or suicidality, but it might not fit the whole picture of a definition at this point. And sometimes we make medicine choices based on targeting symptoms to try to relieve distress. And I'll give you some examples of that here as well. Okay, what does success from medicine mean? You know, I think this is a really important point. When I say that medicine is helpful, it depends on what the outcome measurement is. For ADHD, we expect sometimes an 80 to 90% success rate with symptom control because we know we can get that. With more complicated disorders such as OCD, a successful medication response might be 30% to 40% improvement. And sometimes we're measuring their functional gains instead of just their symptoms. And so it's always important to remember that the medicine may not make it completely go away, but we should be improving function and tolerability. And so knowing what medicine we're using and what the possibilities for success are versus side effects is something to always be mindful of. And I always say that, and many of you have heard me say this, if you're going to use a medicine, you should use it to its full potential. Because if you're only using it at a low dose, but it's not the right dose, you're exposing people to all the risks, but not all the benefits. So it's really important that you understand what your target is and what's possible and what's not possible with regards to the medicine. And number 7, I think is also really important. If the medicine didn't help and it didn't work or the side effects were intolerant after a reasonable dose for a reasonable amount of time, then you should really stop it. I get a lot of kids come with a lot of polypharmacy and often say nothing's helped, nothing's gotten better, things have just been added, nothing's ever been taken away. And sometimes you don't know what's what. And so you have to really remember, if you really don't think it's helped your target symptom or what you were going for in the first place, just stop it. Start fresh, go back to the drawing board instead of adding something else. So if you can, monotherapy is always better than polypharmacy because it minimizes those side effects. We know more about the efficacy of monotherapy agents than we do of polypharmacy in kids. 9, and this is where I think many people on this echo today that aren't direct prescribers really can play a huge role in helping me and helping other members of the healthcare team with continuing just to provide psychoeducation to families and patients about understanding what the medicine's for and targeting symptoms that might be interfering with therapy, or if a patient voices something that sounds like a side effect, really making sure that they call the person writing the prescription to really let us know, because sometimes you might be the first person to see something. There have been a couple times in my career where I've had a physical therapist or an occupational therapist or a school teacher call me saying, you know, I noticed this. One, the medicine was wearing off, or I had a teacher pick up on actually a tardive dyskinetic movement from antipsychotic because they were having facial movements that ended up being a side effect. And so I think that all members of the healthcare team and all people really are helpful to this process, especially people that you have really long-standing relationships with and something shows up to be different. It's really important that we always educate that this is a long-standing relationship and monitoring that goes with it. I think medicating kids is a really hard thing to talk about in general. General sort of ideas that kids shouldn't need medicine, they should be healthy, and that we shouldn't need medicines for mental health is sort of a standard stigma. And it's hard for parents to give their kids medicine. They sometimes feel like failures of parents, or that it's something we should be able to fix without it. And so it's really important, again, that we're operating in the evidence base, but it's also really important to ask question number 10. What's really the risk of not treating this? Okay. And sometimes those, and you all know this better than anyone, sometimes the risk of not treating are pretty severe. What's the risk of not treating severe depression with suicidality? Suicide is the #2 cause of death in all pediatric patients. And so not treating severe mental health issues really do have lethal outcomes. What's the risk of not treating ADHD? What are the long-term consequences of untreated ADHD? Lower school performance, higher rates of anxiety and depression, higher risks of accidents and car accidents and interpersonal difficulties and low self-esteem. There may be more benefits to treating than not treating, and that needs to be weighed for each individual patient, each individual family. It's a really important question to ask. 11, we never stop monitoring side effects. Side effect can really occur at any point, at any time, and be real strange sometimes. Even if it's not common, things do happen, and so we can always be vigilant. Number 2, diagnoses change, and this is really important to remember with kids. Sometimes the diagnosis changes because of a disclosure. If you've been treating a child with anxiety and depression, and they suddenly describe trauma or a history of traumatic events, maybe their diagnosis really is PTSD, and the treatment plan needs to change. Maybe you've treated them for depression their whole lives, and suddenly they appear with a manic episode. They no longer have depression, they have bipolar disorder. And it's important that we understand that these diagnoses evolve and treatment may change as time and pressure and new symptoms emerge. 13, I still consider medications always a choice. I don't think any parent or any provider wants to think about a parent holding a child down and putting medicine in their mouths. But sometimes this creates a lot of anger and war in families about trying to force kids to take medicine. I think it's really important we continue to educate kids why, as they get older, start taking a little ownership in why they take it and what it helps with. And that's a lot of psychoeducation as things evolve. I have a lot of kids that start with ADHD medicine when they're younger, and they've been largely well medicated and done well most of their lives. And at some point, inevitably, and the research says about 95% of the time, when kids get to be a teenager, they don't want to take the medicine anymore. They also aren't aware of remember what the side effects were of not treating it or what problems they had. And so it's pretty common for them to want to take a break. And I really spend a lot of time saying, okay, let's take a break. But these are the things I really want you to watch for, and make sure you're still having success at school, and make sure that you are still able to pay attention and focus, and engage the child in a choice as they're able to comprehend that and provide that. But it's still really important developmentally to understand that kids still need a lot of help, even into college. And I have a lot of parents who I think wish that their teenagers could remember their medicine every day and not need reminders or be fully responsible for it. And realistically, it's still hard for a lot of adults to remember. So while medicines are a choice, they still may need different levels of support. So I kind of talk more about not being absolutist about it or this or that, but how do you gradually kind of provide support and slowly pull it back in giving children more control and responsibility while you're still trusting but verifying what they need. And 14, I put this on here, sleep is a huge concern. Sleep problems occur with almost every mental health condition, and there is no miracle pill for sleep. Boy, I wish there were. But sleep is a very complicated issue, and you really have to spend a lot of time understanding the causes of the sleep disturbance, both the behavioral and the psychiatric contributors. And if it was that easy, we'd be millionaires by now. But treating sleep issues is really complicated. And I'm not going to give you any magic answers for that today, other than it's important to follow, consider, and ultimately treat if you need to. Okay, so these are our standard psychotropic drug classes that we're going to go over today. I'm going to try to make it through antidepressants today, and I'm going to save more complicated mood stabilizers, antipsychotics, and lithium, and some of the benzodiazepines for our second part. And some of you have heard me sort of summarize some of the information on this before, so I'm just going to kind of put it all together by class this time. All right, so stimulant medications are all listed here. You can see there's lots of different options listed. What I want you to notice, though, is that there are really only two kinds of stimulant medications for therapeutic purposes. On the left are all methylphenidates, and on the right are all amphetamine products, okay? And the secret is that there are really only two kinds of stimulants. All of these fancy names under each list are really pharmaceutical strategies of packaging those two said different medicines. And that packaging matters because all of these medicines have different length of time that they last, and they all have differences in how much of the immediate release form and how much of a longer acting form releases. And so sometimes the only thing that makes me know what I'm doing is that I really do know the split patterns of how all of those medicines are released. And sometimes that explains what's going on with the child. From a treatment standpoint, these medicines are equally efficacious and all have the same side effects. The difference is that everyone still can respond differently to different medicines. As a general rule, the mechanism of action of the methylphenidate is a slower release of dopamine and norepinephrine in the terminal. So it's not as immediate. This has benefits in that it's been shown that the methylphenidates are probably a little less agitating and might have a lower abuse potential because it's not as immediate as the Adderall or amphetamine products. Amphetamine is much more of a direct release at the terminal of dopamine and norepinephrine, and the faster a medicine releases those chemicals, the higher rates of addiction are associated with it. And it also can be a little bit more agitating as well. And some of the amphetamine has had maybe a little bit more risk for things like psychosis from that increase in dopamine. But apart from those differences, they largely are very, very similar in how you treat patients. And the standard of care is sort of for ADHD to pick a long-acting one for kids in school. So that's usually age 6 and up. Start slow and work the dose up to see how long it lasts. The short actings have higher rates of withdrawal. They don't last very long, and they often, the withdrawal of the immediate release can be a little bit more dramatic and cause a little higher rate of some of the side effects that we're going to talk about, although some of that may be to your benefit if you're worried about things like appetite. But what I want to assure you is that sometimes the first choice of what we pick is sometimes based on what the insurance will pay for. And that's okay. Some of these medicines are incredibly expensive, $700-800 a month. And so as every new product comes on the market, it's often years before it becomes affordable on patients' formularies. So the other sort of thing you have to learn is how to switch between the two as the formularies change. And there's specific kind of details about that, but generally speaking, 5 milligrams of amphetamine equals 10 milligrams of methylphenidate. And there's some exceptions to that, which we can talk about, but they really are one or the other and how they kind of work. So why do we use a stimulant? Well, we use stimulants for ADHD. That is absolutely their indication. Every one of those stimulant medications has an indication for ADHD, all of them down to age 6, and some of the short-acting amphetamines at one point had an indication down to age 3. But they generally have all been tested. And there, as I said before, over 400 studies that have been done about the efficacy of stimulants in ADHD. But sometimes we use stimulants for other things than ADHD. And this is kind of getting into those symptom-based approaches. So some kids that have developmental delays, again, often from organic causes in their brains. And if you remember some of my other earlier lectures, we talked about the in utero impacts of substance abuse or toxins or in the case of attentional brain injuries, where sometimes the damage to the brain is not at the cellular or receptive level like we think in biologically inherited ADHD, but they actually do not have enough of the gray matter to regulate their motor control. And we refer to that as hyperkinesis of developmental delay. And it may look and feel exactly like ADHD, and we may still use stimulant medications to treat that. And there is some evidence base of using stimulants, low-dose amphetamines, and methylphenidate to treat kind of attention and focus problems in people with traumatic brain injuries that have frontal lobe issues as well. The difference is the dosing is pretty different. In ADHD, you tend to start low and work the dose up. In many of the more direct impact on the brain symptoms that cause hyperactivity, the higher you can kind of get a sweet spot where a little bit helps, but their brain kind of can't handle the load of too much, which is a little bit different when it's a receptor cellular problem. So you can get more side effects in some of those. And there actually are some indications in severe depression to use stimulant medication because stimulants release dopamine and norepinephrine, similar to buprenorphine, which I'm not buprenorphine, Wellbutrin, bupropion, we're going to talk about as an antidepressant. Sometimes that helps with motivation and energy in people that are really struggling to kind of get up and go, has been used as an add-on. With stimulants, as I said, timing is absolutely everything. Those long-acting medicines, so all the ones that had ER, SR, LA, after the kind of the name, that reflects that it's a long-acting medication. And the definition of long-acting is really to cover the school day. So you may have anywhere from 8 to 12 hours. The short-acting medicines, the ones that will say IR or immediate release, sometimes are anywhere usually from 3 to 6 hours. And everyone can metabolize it differently. And so it's important to note that it's not a 24-hour pill. And I have a lot of parents that wish the stimulant was 24 hours, but what it means is understanding as you assess people's response to kind of ask, well, when do you take it? When does it kick in? When do you think it wears off? And I got fooled really early in my career as I had a lot of parents that would be like, it's not doing anything. It's as bad as it was. I don't think this medicine's helping at all. Well, the parent wasn't seeing the medicine's benefit because the child was taking the medicine at school, clearly was gone by the time they got home from school, and they weren't given it on the weekends. And so it's very hard sometimes for parents to realize these medicines only work when you take them. And when they wear off, it all comes back. And so you have to provide a lot of education about that. But you also have to query when they come back, what hours am I covering? Am I covering enough hours? Are there problems occurring when I'm not covering things? And this may lead you to kind of change your options for treatment or to think about extra doses. So the most common sort of dosing strategy is to give a long-acting to get through the school day, sometimes with a short-acting dose to help cover homework and difficult behaviors occasionally in the evenings, and balancing that with any side effects that might be going on. All right, so stimulants have side effects, and they're often very specific to the dose of the medicine. And so appetite suppression and stomach aches are clearly common side effects. And so you almost get a little bit of appetite suppression with all stimulants. Now, that should not significantly interrupt growth. And so although there's some initial suppression in appetite, or even sometimes some initial suppression in height, most data suggests that will get better over time. In fact, while there's a risk of weight loss from stimulants before puberty, the dysregulation impulse control has actually been shown to have problems with obesity in adulthood because people don't self-regulate very well and have impulsive eating. So the appetite effects are much more common pre-pubertally. And most of the time, the biggest outcome in growth suppression at most, which it recovers, is about 2 centimeters, which is about two of my fingers, which is not substantial for most people, but some people will hear about growth suppression and think, oh, my child's really going to be almost like made fun of because they're so small, and that's a little bit extreme. But we do spend a lot of time making sure they're eating, making sure they're making their nutritional gains, and keeping an eye on their growth chart. If you see a substantial decrease in their growth trajectory, usually considered 20 or 25% drop off on their growth curve, you might want to consider a change in the treatment plan. If just eating smaller doses and high calorie rich foods do not help. Stimulants taken too close to bedtime can impact sleep architecture and cause some sleep problems. This is challenging because lots of times kids are so hyper, they already have insomnia problems and have trouble kind of settling down to go to sleep. So you have to balance that. Tics used to be listed as a side effect of stimulants, but this has become actually pretty controversial, and most studies actually suggest this is not true anymore, despite some of the initial reports. In fact, in some long-term studies with kids and tics, they found about 10% of all kids with ADHD also have tics, also related to dopamine dysregulation and some genetic links. And it turns out that over time, most tics get better, even if you treat them with stimulants. So while I still have a few people that clearly have this effect, the vast majority of kids, the ADHD is more impairing, and you still choose to use stimulants with the understanding that the tics will probably get better and wax and wane with time. Some people really get moody when the stimulant kicks in. This may be irritability or moodiness or just strange, weird mood issues. You can have this when a medicine kicks in, but you can also have it when the stimulant wears off. Some people get a withdrawal dysphoria or withdrawal moodiness that lasts about 20 to 30 minutes toward the end of the medicine that can be quite notable. It's important to figure out if the moodiness occurs when it kicks in or where it wears off, because the treatment might be very different. If you have a higher dose stimulant during the day and the wear off causes that withdrawal dysphoria, sometimes a small step down dose of short acting actually relieves that immediate distress, and you can keep someone on their medicine. If the moodiness is really significant when the medicine kicks in, you may need to change the treatment altogether. We monitor vital signs. There's also a possibility of a slight increase in blood pressure and pulse. For most kids, it's only a few points and not really significant, but certainly kids with some cardiac problems or worries about cardiovascular risks, that few points might make a difference. So if you have a child showing high hypertension or other sort of cardiovascular issues, we often try non-stimulants, or we also frequently ask the cardiologist to kind of weigh in to see if this is an underlying condition or being made worse by the stimulant. Again, pretty easy to check because you can stop the stimulant for a week or two, recheck the blood pressure, and see if you notice a difference. So we can follow that pretty closely. Affective dulling is the complaint of my child looks like a zombie, and this usually occurs from too much medication. So in ADHD, if I gave people without ADHD stimulants, they would have a stimulant effect where they would get maybe hyper or high. In kids with ADHD, that's not the case. They actually become sort of zombified and have limited facial expression. And that's a result of too much medicine, and usually lowering the dose corrects that. Certainly, parents are always worried about, it's a controlled substance you want to give my child. I'm worried about future substance use, and the data actually shows that treating ADHD before puberty with stimulants actually reduces the risk of substance use in teens. We know that actually untreated ADHD is a very big risk of developing substance use problems. And so again, that may be one of the benefits of considering stimulants. The bigger issue, I think, is if you have an active substance user in the household or concern about it being diverted, stimulants may not be the best choice for the family. And so you might have to make decisions about having the school give medication or consider non-stimulant options that might be present. And there are warnings on all stimulants in predisposed individuals. They could cause psychotic symptoms or mania. Again, usually people have some predisposition and the stimulant kind of triggers those, but those are incredibly rare events. There was also some warning about sudden death from stimulants that came out in 2004 when Canada briefly pulled Adderall from the market and caused quite a stir. And so some of them have a sudden death warning. on that, which always terrifies parents. This was actually pretty limited to kids with concerns regarding underlying cardiovascular events, specifically like enlarged hearts. That increase in blood pressure and pulse could be quite problematic. But when this came out, people got really scared. Lots of kids stopped their stimulants, and lots of parents and schools struggled. And so I don't see this fear quite as much as I did a decade ago. But there's a beautiful guide for parents, and there's actually one for depression here too at this website. So it's www.parentsmedguide.org, and it has parent handouts on going through what to consider about stimulant medications, as well as depression and bipolar disorder, and a very nice sort of help parents walk through the risks and benefits for that. Generally speaking, if a child has not had exercise intolerance, personal history of shortness of breath, or an early family history of sudden death, in someone from like drowning or from a cardiovascular event, there's actually no specific guidelines to get an EKG or any monitoring beyond asking. And you kind of learn a lot as you do things over time. When I first came to WVU on the sidelines of having all this anxiety from this report coming out, I was like ordering EKGs on everyone. And the chair of cardiology, Dr. Larry Rhodes at the time, like met me. He's like, "Oh, I know you. You're the one that orders all those EKGs. We appreciate your business." He goes, "But you know, those kids running up and down the halls and climbing on things, you know, they're giving themselves their own stress test. They probably don't need that EKG." I thought that was, he goes, that they're already exercising. And I thought that a pretty important thing for me to realize. And I've ordered a lot less EKGs since he told me that. But it is still important to screen people. Okay. The other class of medicines that often gets associated with ADHD are your alpha-2 agonists. These are medications that essentially block norepinephrine, and most of their effects are actually in the periphery of the body, so not just the brain, although there is some impact on the brain and the prefrontal cortex. These medicines have a lot of impact on like the adrenal system, so they're reducing kind of the adrenaline rush, so to speak. And they're all blood pressure medicines, so they lower blood pressure, but in doing so, they kind of decrease hyperactivity and impulse control. So the two medicines in this class are Clonidine and Guanfacine, and they both have extended release forms as well. The Cat-Fe of Clonidine is a twice-a-day formulation, and the Intuniv is a once-a-day formulation of the Guanfacine. So both of these medicines are FDA approved for ADHD. They are actually approved not only as single agent treatment, but they also are approved as add-on treatment with stimulants. So if you have someone that can't tolerate higher dose of stimulants, but still have lots of symptoms, you can add an alpha agonist to the stimulant, and it's FDA approved for that purpose. Because of some of the more peripheral activity of these medicines, I think these medicines are much better for hyperactivity and impulsivity symptoms. There's some thought that it helps attention and focus, but the impact is probably much lower than the stimulants because they're focusing and paying attention, largely probably because they're sitting still a little bit better. There has not been neuropsychological data that has come out actually showing it really improves attention. It's more the teacher's perception of attention, which is helpful, but I see a lot of kids that get treated just with alpha-2 agonists, and the parents are like, well, they sit still, but they can't pay attention. And that's probably related to the medicine. But because it blocks that adrenaline sort of surge, it does actually have some other purposes. Sometimes we have kids with significant PTSD symptoms, hyperarousal. It suppresses some of the REM and dream sleep, so it can be helpful for nighttime nightmares and flashbacks. Clonidine is actually pretty sedating, and sometimes we use it to treat sleep problems related to ADHD. So the kid that's so hyper, they can't settle down to begin resting, Clonidine is sometimes a nice choice for that. And again, sometimes we use it we talk about sort of that symptom approach. Sometimes if kids are so impulsive, it becomes aggressive. Lots of times we might want to try a medicine like this before jumping to a more heavy duty medications like an antipsychotic to help with impulse control. So it can be added on for that. And then again, somewhere along sort of that effect, that blockade of that adrenaline surge, some people report some improvements with anxiety that can happen. The other thing I actually realized I left off this list and need to add back is these are your first line medicines we use for tics as well. So before, again, going to antipsychotics, often guanfacine and clonidine are first line treatments if you decide to treat tics. Lots of times we just watch the tics until they're problematic and try not to treat them. But for kids that are really bothered or disturbed by your tics, we usually choose a medicine in this class. The biggest side effects from these medications are dizziness and sedation. And that comes from the fact they do work and lower blood pressure slightly. For most healthy kids, they adjust and adapt pretty well. And this is pretty insignificant after several days of getting used to it. But in the titration phase, you have to go a little bit slowly. For people that take their medicine a few days and stop it the next day and have trouble with that, these are not great medicines because the sedation will improve if you take it consistently. And those changes in blood pressure aren't good for people that can't be consistent. But if you don't have sedation and dizziness, they're generally pretty well tolerated. And if you work it up slowly and people are consistent, people can tolerate it pretty well. Again, because there's an adrenal blockade, there's always mood symptoms that some people will report, like fatigue, tiredness, irritability. Okay. Next is Stratera. This is another FDA-approved medication for ADHD. This medicine actually works like an antidepressant. It is a selective norepinephrine reuptake inhibitor, so it increases norepinephrine in the frontal lobe and frontal motor cortex. And because it works like some antidepressants, some people have speculated, will it help anxiety? And some data does show that it kind of helped anxiety a little bit, but it has not been shown great evidence as a primary anxiolytic or primary antidepressant. But this kind of gets back to sort of this comorbidity issue that for a lot of kids with ADHD, it is so anxiety provoking to not pay attention. They get so anxious from missing things or feeling like they're missing things, or they're so anxious about not performing as well as they can, that actually treating the ADHD, either probably with Stratera, even stimulants, have really actually shown to decrease anxiety in most kids. And so it's hard to tell kind of which came first there. There's some mixed studies on efficacy. Some studies have shown them to be equally efficacious to stimulants, but some really have shown that a lot of people do not respond. And some of this may be age dependent, that hasn't been sort of linked out. We know that a lot of young children, so kids, prepubertal children, like before 12, don't handle medicines that have antidepressant action very well because they haven't yet built all the neural pathways to handle some serotonin and norepinephrine effects. And so sort of if you pull all the data on efficacy, while stimulants seem to carry an 80-85+% efficacy, Stratera studies kind of globally have about a 60% efficacy. So there will be some people that just don't respond to this, okay? This is a slower medicine. You have to start low and work up the dose. It is the only medicine I prescribe that is actually weight-based. So you usually start at 0.4 mg per kg, and you want to work it up usually between 1.2 and 1.4 mg per kg, and that may take several weeks, and people have to be patient to see the effects of it. And sometimes I think people don't stick with it long enough or get to the right dose to tolerate it. I think it has a little bit more risk of stomach aches for some kids and nausea, which is some of the limiting factor. But if you tolerate it well, some studies have even pushed the dose to 1.8 mg per kg. The really cool part about this medicine is if it does work, and you're one of those 60% that respond, it really does have 24-hour coverage. So the families I have that have a lot of wear off, or they have a lot of behavior problems associated with their ADHD, where they have that on-off effect from the stimulant, and evenings and mornings are just terrible, Stratera might be a really good option just to kind of keep things more even throughout the day. Because Stratera, again, works like an antidepressant and has a lot of extra warnings on it. that are also very scary to parents. There's warnings about behavioral and mood changes, and there's warnings about suicidality. This is all kind of overlay from the fact that if you give someone with undiagnosed mania, or you give someone an antidepressant, there's a small percentage of people that might have suicidality. So these medicines carry all those same risks. It's important for me to tell you that there's actually not data specifically on Stratera causing suicidality. It's a class warning that it got for that reason. And so I've never seen a study where Stratera caused suicidality, but as I said, it's a blanket warning. And so that scares a lot of people. Certainly any medicine I prescribe can have behavioral changes associated with it. And so it's important to just always monitor those things. And there's a very low risk of liver failure that occurred in some of the early trials with Stratera. Again, that's so small that they advised against any lab work testing. But I think it's always important to kind of just remember that. There's some thought that it may have less impact on blood pressure and pulse compared to stimulants. And so sometimes in patients with hypertension, I've had pediatric cardiologists sort of prefer this. But Stratera actually may be a little bit more arrhythmogenic than stimulants. So kids with arrhythmias, often they prefer the stimulants. So as I said, with kids that have cardiac overlays, I always consult. And despite all the on and off about stimulants and tics, which again, we think is probably untrue, Stratera has not been shown to worsen tics in any study. I'm actually going to stop there because I want to give a little bit more time to antidepressants than I have left. And so I will save the antidepressants, antipsychotics, and mood stabilizers for next time, and just sort of pause there and give you a chance to ask me any questions about the ADHD medicine.
Thank you so much, Dr. Swagger, for that PowerPoint. And we can certainly work with you to schedule that part 2 of your PowerPoint. But certainly, if anyone has any questions or comments or thoughts that they wanted to share with the group or ask Dr. Swagger, please feel free to unmute or chat in. We always like to emphasize that it's a safe space, so no worries. Dr. Lillard, or I think Amanda was on the call too. She may have had to hop off here, but Dr. Lillard, if there's anything you wanted to add as well, feel free.
This is not my area of expertise, but I always like when Lauren talks about it, because I think for all the providers who are not MDs, I think even as psychologists and other mental health providers, it's really important that we have kind of some baseline awareness of these medications, when our patients are on them, what it's like, what kind of, even if you can remember kind of dosage of things, it's been really important to me in my practice. Just to have a kind of basic knowledge, and to have colleagues next door or down the hall that I can just pop by and say, hey, this is what they're on. Is that normal? Is that okay? Is this a good dose? Is it a low dose? You know, what's going on here? But I think it's very valuable for us to hear about and learn about these things.
Thank you. Yeah, no, absolutely. That must be awesome, being able to just kind of like pop your head into someone else's office and be like, hey, like, what do you think about this? That's really cool. And we like to make sure everyone feels that way in this echo session too. If you have any questions about anything, and even if it's not along the lines of the didactic, no worries at all. Any other comments or thoughts that anyone wanted to share?
I guess I have a question for everybody. This is one that always kind of strikes me. I see a lot of patients sometimes that don't know why they're on the medicine they're on, and that's always kind of baffling to me. I wonder in your work with some kids and patients, do you guys see that as well? Like they tell you they're on a medicine, but they really struggle to tell you what it's for. They just take it, or I really feel like that's a big educational point for all of us, and I think it gets better sometimes, but I still see that a good bit.
my evaluee this morning told me, I have no idea what meds I'm on. I said, well, are you taking them? Are you listening to it? Yeah, I'm taking them. No big deal. It's like, okay.
I can say for my current work, that's something that is with the adults that we work with. My current works with all adults. We try to work on that education piece with those things, but there's also some that aren't open to that quite yet, or maybe aren't understanding the information. We find that at times. I know when I was working more with children and adolescents, they wouldn't always know, or parents would sometimes term things for their medication. So it would be like taking their vitamins, and we would have to provide some education, some discussion about those things as well with them, of the importance of knowing what these things are about and what they're for, and how to identify if they're helping or not, then based on how they're terming things.
Yeah, I think that's a really good point. Vitamins might be more of a neutral way that I hear it reported. I've had parents call it the not be bad pill, or the be good pill, or things that sometimes are linked with kind of these very negative associations in my mind. And yeah, I think again, I think you have to match it to the kids' level, but a lot of kids are smart. They can handle things, and I, it's kind of funny because as kids get older that I've followed over time, sometimes their parents are very reluctant to give them medicine, and when the kid understands how it helps them, many kids their parents will be like, can they come off of it now? And the kid's like, no, school goes so badly when I stop it. I never want to stop it. It just makes things easier. And they have a lot of buy-in and often kind of continuing it. So I mean, that's a huge point.
I don't really see it with my current work with the children I see, but back my previous job, I did a lot of DDS evaluations, and I was doing like the psychological testing portion and some of the like social background. And I mean, I would have people bring in a list. I'm talking 15, 20 medications on there, and I would try to go over them with them and be like, so what is this for? And they'd be like, I don't know, I've been on it for about 8 years. It's a little blue pill. It's and I was always amazed of how many was not aware or didn't think twice about it. And I also want to say I thank you for sharing that website again, because just the other day on a brainstorming session we had with the PBS team, a parent was questioning medications. And I was thinking that at one point in time you shared something that was really useful for parents to look at, and you just share that website again. So thank you. I forgot about that.
Yeah, I'll put another one in the chat too. The American Academy of Child and Adolescent Psychiatry website has a bunch of parent portals too that have like all parent question databases about all psychiatric health. And there's several like handouts on medications, from anxiety medicines to bipolar disorder to just about anything, even oppositionality, and sort of behavioral management. So there's really lots of cool resources that are kind of written at a level that for parents to kind of understand and make informed decisions. So I would add that one to the parentsmedguide.org.
And we'll be, Elizabeth and I will be sure to keep that website as well in the recap email. So thank you for chatting that in, Dr. Swiger. Any other thoughts, comments, questions? We have about 5 minutes left, and I don't want to end the session too short if we don't have to.
I think I already am on the schedule for April 21st, so I will just plan on doing part 2 that day if that works for everybody.
That sounds awesome. Alrighty, well, thank you all so much. Thank you, Dr. Swiger, for part 1 of today's didactic, and certainly we'll keep in touch for part 2 in April. But if there's no other further questions or anything, I'll turn things to Elizabeth for the announcements. Thanks, guys.
Excellent. So the only announcement I truly have is our next session, March 17th. It'll be at 12:30. And Amanda Newhouse will be presenting on discussing and managing sexualized behaviors.
Awesome. Thanks,
All right.
guys.
Thank
We'll see you guys
everyone.
next time. Bye.
Bye.
Thank you.